The patient is 82 years old. He had previous PCI of the left man 2 years ago. And then he came back for a cardiac failure. And as you can see, he had a previous stroke in the past without any sequelae. He had aortic stenosis of 0.5 centimeters square, not indexed. So indexed it will be 0.3. And the Euro score is about 20%. So we select this right femoral artery. You can see it's very large, about 10 millimeter for the femoral. And we decide to use this one, but there is some tortuosities. So now we can move to what we have done before. So this is injection from the left because we decide to use the right, and you can see the tortuosity. We have a good marker for the puncture just to be sure that we have a puncture proximal to the bifurcation because we'll do all percutaneously the approach and the closure. Then we have done an angiogram. So this is a 24 Frenchies because the annulus size was measured by transthoracic 21 to 22 and by transesophageal echo just before the procedure or during the procedure 24.5.
And the dilate, the introducer went very well, very smoothly, much easier than sometimes. So
now we have the 24 Frenchies in place. We wanted to test it because of the tortuosity in the femoral, and you can see it was very easy. Now we have the view that we have selected for the implantation of the valve, which is LAO 13. We have a pacemaker in place, of course, and now we'll cross the valve. So I use usually the GR. You can see we have a pigtail in the right sinus of Valsalva, and we have the GR. I use a straight wire. Usually it works with the GR very nicely. I think we are in.
Yeah, you are in.
You know, many different techniques people use. There were 3 different catheters people use generally, and Thierry is crossed very nicely with that right Judkins. We generally use a straight stiff wire, usually a glide wire, and people use either AL1s, multi-purpose, or right Judkins catheters to cross, and Thierry is very.
So maybe we can show the gradient. So this is a gradient which is about 50 to 60 millimeter of mercury. And now we have a straight wire, a stiff wire. So can we go back to the room and show the wire? Here?
So we'll now exchange for an extra stiff wire, not a super stiff, but an extra stiff.
Yeah.
That will give you support for both the balloon and for the device. And Thierry is going to shape it.
Yeah, so it's very important to have a good shape because we want to have this wire in the apex of the left ventricle. And it's very important to have also a good support and safety in terms of wire placement in the left ventricle. So now we'll go with this wire and do a predilatation with a 23 millimeter balloon.
Now, generally, when we implant, in 90% of men, they get a 26 millimeter valve.
Yeah.
In this case, with an annulus that's between 21 and 22, we tend to oversize by 10 to 20%. So definitely the choice should be a 26 valve, which is why a 24 sheath was used.
So now we will just fill the balloon just to be sure that there is no bubbles.
No air in it.
Can you do it?
Vas-y.
So I agree that the CT can be very useful. For this patient, we have not used the CT because the creatinine level is not perfect. There is still some bubbles. So we decide not to use the CT because femoral artery was very large, so we had no doubt about the possibility to go through even with the 24 Frenchies.
What you're seeing on the inset, by the way, is they're doing the valvuloplasty. One of the technologists or Edwards representatives is now crimping the valve on the delivery system, putting it in the loader. So all this is being done in parallel, and that's a process that takes about 20 minutes.
So now we'll predilate with a pacemaker. Usually we start with 20 millimeter of mercury with 200 per minute. Okay, Mireille, you can do. Pacemaker on. Okay.
So this will be rapid VT,
okay.
which we now use pretty frequently for all of the valvuloplasties.
Okay, so Marty, why we are doing that?
I do.
Raphael Amor has prepared the valve. So maybe, Raphael, you can show the valve, the crimper, the flex.
That's my good friend Raphael Amor.
Okay, yeah. Yeah, I think that everybody is known worldwide now.
I think Raphael has prepared more than 400 or 500 valves. 300? Okay, 300.
So the valve is in the loader over there. And you see the extremity. This will be, no, this one, please. And this will be inserted in the sheet. So, okay. I put the wire in the valve.
On the extra stiff wire.
Yeah, it's
the pre-dilatation has been done.
Yeah. And the pressure is back.
Quickly.
The pressure went to 60 after the pre-dilatation, but now we are over 100.
So now Marie-Claude will continue the case, and it will help her, just to show that it's a team approach.
Okay.
We often at the same time have somebody who works the TE echo, who's talking to us about, is the valve more mobile? Is there much TR? Those kinds of things. Things to look out. And sometimes actually for placement we're using TE echo to assist a little bit. The loader is placed into this triple gasket sheath system, and then the device is advanced. Sometimes the loader can be in either too far or not far enough. You see that Thierry is struggling.
Okay.
So now we
there it goes.
We'll push the valve. Can we show the valve? Okay.
You should watch it. The sheath is 45 centimeters, so it's well up in the aorta. You see the stent, which on a 20-stick valve is 16 millimeters in axial length.
Okay, so before going outside, it's very important to check that you are still in the left ventricle.
There's the edge of the sheath. You can see the circular radiopaque marker just about to exit right now, right there, just exited the sheath. Now this is essentially the point of no return. As Thierry is approaching the arch, he will begin flexing the catheter. And he'll begin placing the patient in the LAO.
So now we move in the LAO
to assist with.
Okay. No problem. So this is very important, Marty, as you point out.
Critical.
It's very important.
Yeah, the wire remains very stable.
Yeah.
To be sure that you do not touch the arch. C'est bon, tu peux y aller. Point fixe.
So we try very hard to keep
it
I'm
off
flexing
the outer while
flexing,
is pushing.
The arch, so he's flexing it.
Yeah.
You see this?
Yeah.
That's nice. This may be where some of the strokes come from. If you
absolutely.
Exactly. So it's very important not to touch the arch,
so he's approaching now with almost
internal
5
part
full
or
turns
external
of flexion as he approaches the valve. This is a relatively horizontal aorta.
It's also nice because
and you also see it's lifting the wire up out of the commissure to the central valve plane.
Right, because the valve always tends to want to go into the right coronary cusp. And you need to lift it up to get it to the center of the
right coronary cusp.
So now, before crossing the valve, we prefer to go back to the view that we have selected for positioning, because sometimes...
The implant view is very important.
Yeah, sometimes you see the pressure which is going down when you have crossed the valve. So now we are in place, ready to pace, and Marie-Claude will start to push in order to cross the valve. Okay. So sometimes it's hard, especially when you have calcification like here.
Okay. So
now you see it's crossed.
Okay.
Now the first thing that she'll do is remove the flex cath. You see the flex cath is back now.
Exactly.
Now we're going to do final positioning. Now usually the patient is very stable at this point.
Yeah, if you show the pressure, it's good.
Okay, so now we are the most difficult part.
You should try to be patient.
Yeah.
Very important part right now.
So we make an angiogram with this position.
About
60-40 on the ventricular.